Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast today, episode 326. My name is Terry Fletcher. So today we are going to revisit a topic that I did in September, only because I'm getting a flood of questions about it on my Coding Corner membership. And so let's talk about that complexity add-on code, G2211. For some of you that don't know what that is, let me kind of revisit it for you so you understand. So CMS came out with a new add-on code, and it's add-on G2211, and it is for what they call a complex or serious condition patient. So remember what I said there. I didn't say chronic. I said complex or serious condition. So the definition says visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. And then in parentheses, it says add-on code lists separately in addition to an office or outpatient evaluation and management visit, new or established. There's a lot of information in the final rule, and I'll give you some cited references. But the one thing that keep in mind, this is going to sound a little bit like a cautionary tale, because CMS came out and said, this will probably be reported around 38% of the time. But what I'm hearing from practices is I'm thinking it's going to be reported 80% because there's no safeguards on it. There's no frequency guidelines. There's no listed diagnoses. They've only given us what not to do, instead of what to do. There's no documentation guidelines. And so there are some limitations on when you can report it. And I'm going to talk to you about that as well. But I just want to make sure that you're not over-reporting or under-reporting, and that if you're going to report it, that you're reporting it appropriately. So what this code actually, why it came out or why it was added is because CMS and the primary care associations and physicians got together and said, an E&M visit doesn't really, expense-wise, cover what we do for a patient, not just in that encounter, but from and I'm air quoting, a longitudinal relationship standpoint. So what they're saying is that you have to have, and I'm going to use that phrase again, longitudinal relationship. That means a long-term relationship that adds that resource expense for that patient for a serious and complex condition to your practice. And so there's going to be a share of cost to the patient, so be aware of that. And it also, when they break it down, they're allowing physicians who are of certain specialties to also bill for it. Now, they haven't said, well, this specialty can't, but they say, here are specialties that would be less likely to report it. And so a couple of bullet points first. So this was first released in the November 2nd final rule, and then updated, of course, in last day of December in the final rule. And then now we've seen some new information that has come out in some transmittals, and I'm going to give you a current transmittal. So it's transmittal number MM13272, and also it was a change request 13272. And so just remember that it started with R12370CP. So right now you're dealing with change request 13272. Somebody had transposed numbers when they sent it over to me, so I just want to make sure. And also remember, whenever you are looking at a MedLearn Matters article from Medicare, which is the knowledge resource training bulletins, if it says effective date and implementation date, those are two different things. Effective date on this transmittal says January 1st, 2024. And then what that means is that's when you can start using it. Implementation date, which says January 2nd, 2024, that's when the payers, so the Medicare administrative contractors, that's when they have to have their edits in. So implementation into their system. So that's an internal implementation. It has nothing to do with your office. You can bill it as of the effective date. There's also a release date on there when they basically tell us about it, but always remember you're looking for the effective date. So that's something to keep in mind. I think some people, and I know I've seen that email come across saying, well, it says we can't implement it until. No, that's not what that means. Implementation date means that's when they have to have their edit set up. So if it's coming across and there needs to be an edit for example, there is one, when it's reported with any claim that also has a 25 modifier on it, they will deny that claim. And so here are some of the kind of the actionable bullet points, and then I'm going to get into some details just so you know. So G2211 add-on goes with 99202 to 99205 new patient office visits, and 99212 to 99215 office visits that are established patient. I'm surprised it goes with new patients, because how do you support that longitudinal relationship if you've never seen the patient before? So that kind of surprises me. So I don't be surprised if they deny or question records on new patients that are billed with this code. It also talks about, again, the 25 modifier. So it says it will not allow the add-on code to be used within an E&M service if modifier 25 is appended to the E&M service. Well, here's something that's interesting. There are some edits with, let's say, preventative and E&M, and that if you do a preventative and an E&M on the same date, and let's just say you throw this code in there, you're going to have a 25 modifier in the E&M, it'll get thrown out. What if during an E&M service you also did an injection? Can you bill this code? No. What if you did a vaccine? What if you gave a patient a vaccine or an immunization? There's edits saying that a 99213 or 4 needs to have a 25 modifier on it with vaccines. Will you be able to add on this code? No, because it'll get kicked out. And so, this code is used for practitioners who basically their E&M service is the brunt of their services. This is what used to report most of their services. So when saying that was from the page 428 in the final rule. They're saying that this is probably not for surgeons, but hold that thought for a second. So it also says not all evaluation and management services will be eligible. And you have to hear this, because I can't tell you how many times on telehealth people don't listen. They're basically just saying, okay, well, what about this? And I'm like, okay, how many times can we say it this way so you hear it? So this E&M complexity code add-on again, it said would not be, and this is from page 432 of the final rule. So when you Google and find the final rule, this is where you'll find this. It says would not be appropriately reported, such as when the care furnished during an office or other outpatient E&M visit is provided by a professional whose relationship with the patient is of a discrete, routine, or limited time nature. So they do provide specific examples of conditions that would not require the add-on code. They had mole removal, treatment of a simple virus. They didn't say which viruses. Allergies, seasonal allergies, a new onset of GERD, treatment for a fracture, or when the billing practitioner has not taken responsibility for ongoing medical care for that particular patient with a consistency and continuity over time, or does not plan to take that responsibility for subsequent ongoing medical care. And remember, it's not just medical care for complex patients. Or for chronic patients, keep that in mind. It's for complex, serious problem that you're dealing with. And then on page 429, it clarifies acute conditions. It says, we clarify that this is the relationship between the patient and the practitioner that is the determining factor when the add-on code should be billed. So this is where it's going to get a gray area when you're using mid-level providers. So it says first, the continuing focal point for all needed healthcare services describes a relationship between the patient and the practitioner when the practitioner is the continuing focal point for all healthcare services that the patient needs. They didn't say some. They didn't say just pertaining to that complex condition. They said all. They have, for example, a patient that has a primary care practitioner, again, this is what this is primarily for, that is the continuing focal point for all healthcare services. So that's where they get the referrals, etc. And the patient sees the practitioner to be evaluated for sinus congestion. The inherent complexity that this code captures is not in the clinical condition itself, sinus congestion, but rather the cognitive load of the continued responsibility for all other needed services for serious problems, serious single conditions. Okay, so if you're looking at the final rule, the span of where this is covered is page 428 to 445. And it's really up to you to find this information. I'm giving you the cited reference, so you need to find it and basically put your headphones in and just read through it with nobody bothering you so you can really understand when you can and when you can't bill for it. It's also in 85 Federal Register 84570 and 84571. There were also some questions that came up on, they also give some more information where when they talk about taking the responsibility, they're very specific about, quick fixes, when they talk about GERD or when they talk about a fracture, things like that. But one of the services that I actually belong to as well is from Coding and Tail, Betsy Nicoletti, and I appreciate her information. We don't always agree, but we do come close to certain things. She has some questions that had come up on a Q&A that she was dealing with. And she said, what if two providers of different specialties bill this for the same data service? Well, CMS doesn't address that. So, without any further insight, both should be paid, but you never know what could happen. What about if you bill it with prolonged services? Let's say you have an extended level 5 visit with the extended time and that's all supported. As long as there's not a 25 modifier anywhere, I would think that would be appropriate. And it doesn't really talk about other specialties, but it talks about in the final rule, it does say specifically, so who can bill for it? And when will we see denials? It says specifically, we took into account, and this is a quote from the final rule, the likelihood that primary care specialties will have a higher utilization of the add-on code G2211 than other specialties. Surgical specialties will have the lowest utilization since they're less likely to establish longitudinal care relationships with patients, and other specialists are more likely to have longitudinal care than surgical specialists, but less likely than primary care. To me, that says a lot of that we're not really sure what we're going to do with it, but we're going to be watching what you do with it. Now, the other thing when you talk about this, and keep in mind that 25 modifier edit, there's also some contact person at CMS. Again, you can find this on the transmittal 13272. And there was a discussion, and thank you, Arlene, for this, one of my Coding Corner clients. She's on top of this as well. She said that she had talked to a source there and asked if the NPP has this, can they bill for this? Well, if they have E&M services within the scope of their practice, which most do, they could possibly report G2211. But if they're seeing the patient for an acute condition, and is it the same as having one of the primary care doctors in the same group practice as the patient's focal point of care? Well, he couldn't answer that question. But we are hopefully looking at more documentation and more guidance from CMS coming out in the next week or so. And we will try to update you on that. And also you'll hear it in my first quarter in March, my first quarter Medicare update. So please take those webinars. It's so important that you get the information in a webinar format so that you not only have the cited references, but you have the PowerPoint information. So if you have to bring it back to your providers, you have it beyond just listening to a podcast or listening to information. That also brings me to a point that I want to talk to you about with the Coding Corner. So what that is, for those of new listeners that I have, and I know I've seen an uptick of about 20% of new listeners, we have a membership service that allows you to ask unlimited coding questions via email. So you can't call us because we're in different parts of the country, but you can ask through email and we respond within 24 hours. We help you with compliance, billing, coding if it's under our specialties, and you can find it at terryfletcher.net. Pull down services, and it's the first option there. We have an executive membership, which includes an Ask Me Anything Zoom call. So we have that quarterly, and then also some discounts and webinars as well. So take a look at that, because I know a lot of you are trying to slide into my DMs and say, send me this, send me this, send me this. I do so much research and I take so much time and expense to find this information for you that we don't give it away for free. I mean, if you want to find it, you are on your own to find it as well. But if you are a member, we're more than happy to share our expertise with you, because that's what you're paying for. So we appreciate you respecting what our policy is on that. And I'm very clear, especially when I post to LinkedIn as well. I usually will give a cited reference or information in the article that I post. But if you need more than that, please join our service. Again, we're more than happy to have you, but you need to join our service. The Codecast podcast is also sponsored today by Part B News. Each week, Part B News delivers Medicare Part B regulatory coverage, plain English interpretive language and guidance, fee schedule updates, compliance hotspots, CEU opportunities, and best practices for submitting claims, coding, and more. Every dollar collected, your practice deserves. Start your subscription today. Learn more at codingbooks.com, a Decision Health company. So my personal tidbit this week is that we were supposed to have a playoff for the Steelers over the weekend, and it was actually moved to Monday because of Buffalo, New York weather. And so I'm recording this prior to knowing if we won our first playoff game in the wild card, which we basically luckily slid into. So far, I don't know. That's why I'm in a good mood, because we haven't played yet. But you'll find out next week if I'm still in a good mood, if we won or not. But hope we did, and we move on to the next round. So we'll find out how that works out. But everyone, hope wherever you are, you're getting your vitamin D. You're really staying healthy. I know it's cold out there now that we are in the January month. It's cold in California too. We are in the 50s. I know, sunny and 50, but we're freezing out here. But this is who we are in California. So for those of you in the snow weather, it's really pretty to look at from afar, but stay warm and stay healthy. All right, everyone, have a great rest of your week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.